good afternoon or midday, good afternoon to everyone. I'm really looking forward to talking to you about treating trauma and BPD with the combination of DBT and prolonged exposure therapy. I am not sure how many of you have knowledge about DBT in general, so I am going to go through in this first half and do an overview of dialectical behavior therapy, the treatment, the theoretical orientation, and then we'll stop for questions then, so that if there's any questions that you have that are specific to DBT, we can kind of take care of those and then move into talking about prolonged exposure therapy as it is on its own, and then finishing up with how the adaptation of having DBT and prolonged exposure together works and why it's beneficial for our clients who do struggle with borderline personality disorder and comorbid PTSD. So we'll try and capture things in that way. All right, so let's get started in talking about dialectical behavior therapy. So this is the DSM-5 criteria for borderline personality disorder, which I'm sure most of us are familiar with. I'm going to jump to this next slide and spend time on it instead of the DSM criteria, because this slide is really important. It's kind of the scaffolding of understanding the symptomatology of BPD as it is laid out in DBT, and also understanding how the skills manual is set up from this list of symptoms and their categories and what have you. And also why I'm not going to spend time reading through the criteria from the DSM is because what we've found is that when you talk to a client who struggles with BPD and you show them that list, it can be a bit unsettling, and at times clients will say that it doesn't resonate with them, that they're not quite sure what to make of it, because you have this kind of really diverse list of symptoms and this arbitrary idea that if you have 5 of these, then you meet criteria. If you don't, you have traits and medical model language like that, which is fine in various settings. Just with using this treatment modality, we found approaching the discussion of symptoms and diagnosis to be beneficial from this approach. So we have these 5 areas of dysregulation, and basically those 5 areas are emotion dysregulation, interpersonal dysregulation, self-dysregulation, behavioral dysregulation, and cognitive dysregulation. So for those of you who have a DBT skills manual, you'll probably recognize some of these categories. The skills manual has an emotion regulation module, an interpersonal effectiveness module, a mindfulness module, a distress tolerance module. So these categories of symptoms are essentially addressed and mapped onto those modules in the skills manual. And this is also really beneficial when we talk to clients about these different categories and link it to those sections of the manual, that they'll say, oh, okay, like this helps me to kind of orient myself to when I'm having a hard time with X, Y, and Z, that I'm going to this particular section of the manual, because the manual is very big. And so that can help to kind of fine tune and hone in. And of course, these all work at, kind of intersections. It's not that they're, completely discrete. And like I said, it can be beneficial for the client to help understand what's going on for them. Cognitive dysregulation is addressed more so with CBT techniques and ACT techniques. Yet again, like I said, they're all kind of intertwined and can be used together. So just to give an example, With emotion dysregulation, that is where the person struggles with anxiety, rage, depression. So that's encompasses the mood component of the disorder. Interpersonal dysregulation is where people struggle with attachment in terms of being able to go towards relationships in an effective way and maintain them, a lot of times because of fear of abandonment or fear of being rejected, that there'll be a lot of interpersonal chaos and the person ends up, unfortunately, doing the very thing that they fear of pushing someone else away and being left, because they're either going towards and pushing for reassurance too much, that the other person gets exhausted from that, or they are pulling away preemptively and the people in their lives are confused by that and end up giving up on the relationship. Self-dysregulation is the idea where someone has a strong kind of chronic sense of emptiness or void or kind of a black hole or chasm within that they're constantly trying to fill. And a lot of times that this is something that they try to fill outside of themselves externally with other people, as opposed to being able to have the affect tolerance to connect with themselves and be able to manage that on their own. It's also where we put dissociation as well in terms of symptoms. And this is one of the aspects, I think, of BPD that's the most difficult for our clients and often can drive the next category, which is the behavioral dysregulation, where a lot of clients will engage in self-harm because of that chronic sense of emptiness and the anxiety that it pulls for, as well as with dissociation to try and keep themselves from dissociating or perpetuating the dissociative experience. So behavioral dysregulation encompasses the self-injury part, whether it's cutting or burning. There's also self-injurious behavior that is harmful to one's physicality, but may not be as detrimental, depending. So eating disorder behavior, substance abuse behavior, but they can move into life-threatening behaviors. Also, the impulsivity and suicidality are captured in this category. Cognitive dysregulation is the idea that the person's thinking, and this happens with anxiety and depression as well, but that the person's thinking becomes very kind of rigid and all or nothing and very narrowed down, and that they can have a hard time seeing the gray in situations as opposed to only the black and white. Hence why the main kind of component of dialectical behavior therapy is the idea of dialectics, which we'll get into later, and trying to help people move out of that rigid thinking process and seeing kind of more of the gray, as I said. Paranoia in this category is not analogous to schizophrenia. The paranoia that comes up in BPD tends to be more around relationships and fear interpersonally, that people are judging the person, that they are talking about them, or that they're going to, or that people are going to leave them in relationships. And that's intimate partner relationships or friendships or family or what have you. So it has a different flavor than paranoia from schizophrenia, and the reality testing is not as much of a struggle, although sometimes it is, but not in terms of hallucinations or things of that nature, or psychosis, unless they have a comorbid MDD, psychotic features, or bipolar with psychotic features. And then that there's a lot of rumination and a lot of obsessing that goes on that then kind of amps up the dysregulation in the other categories that we've just described. So those are the 5 areas of dysregulation, and they map onto the skills manual, and they help the clients to understand, as well as the therapist, the client's symptomatology and where they have expression of symptoms in those different categories. So then we have the biosocial theory, which is the model that helps us understand, okay, what was happening for someone that in their life that these symptoms arose and developed for them. So really this is the idea of the intersection between nature and nurture. The biological part, the bio part, is about our neurochemistry, our genetics, what we're bringing to the table since birth. And then the social piece is the nurture. It's the environment that the person grows up in. And we'll talk more about the environment in a minute. So just to let you know, in terms of the biological, there's kind of three components to what happens for someone in terms of their neurochemistry and mood, experience of their limbic system and what have you in the biological part. So we all fall on a spectrum in terms of temperament. You know, some people are on one end of the spectrum where they're more kind of stoic. They absolutely have emotions. They just don't have a very strong response most of the time. It really takes a lot for them to have a strong response. And then you have the other end of the spectrum where people have this heightened sensitivity to their emotions. And Marsha Linehan has described it as thinking about a burn victim, and if a breeze kind of glosses over a burn victim's arm, they're going to have a much stronger response than someone where a light breeze goes over, just your regular healthy skin. So trying to think of it that way in terms of how excruciating, frankly, these experiences of emotion can be for a lot of our clients who fall on that end of the spectrum with that heightened sensitivity to emotions. So with that said, if they fall on that end of the spectrum, what tends to happen are kind of this process. There's a high emotional sensitivity, vulnerability that they're already bringing to the table. Something happens that to maybe people in general might not elicit or warrant that kind of response, but something happens and there's an immediate reaction and there's a quick reaction. And it's really, whatever the stimuli can be, it really depends on the vulnerabilities for that person. And so then they have a really heightened extreme reaction or response and a really intense arousal. So there's a very, if anyone has worked with clients or have, know people who struggle with BPD, I'm sure you've seen this, and it's very tense for everyone around as well if they aren't on the more inhibited spectrum. And this is where really the limbic system kind of throws a tsunami over the frontal lobe, and any kind of thinking and problem solving and rational thinking just really goes out the window. So the magnitude of the response to the stimuli is higher than what people tend to experience. And then we have this slow return to baseline. So this could last hours, it could last days. And what's really unfortunate for people who have this experience is that then they tend to go along in their days never having a break from that intense emotional experience. Because if something happens at 10 o'clock in the morning and they're not returning to baseline, if they ever do, until 3 o'clock in the afternoon, there are so many things along the way between 10 a.m. and 3 p.m. that can actually spike that experience again and cause some kind of reactivity and maybe cause some behavior that's ineffective. And then here they are again in that state, but maybe even a higher level of dysregulation because they've already got that vulnerability from the first spike going on. So it's very uncomfortable, it's very difficult, and actually linking this to the prolonged exposure therapy piece, the work that people start to do with DBT on its own is very important in terms of being able to shorten this return to baseline, the amount of time that it takes, and being able to navigate their emotional vulnerabilities or vulnerabilities in the environment to reduce their emotions and their dysregulation, getting that intense in the first place. And all of that is work in general for living with borderline personality disorder, but also in terms of the trauma work, that people can't go into the trauma work with that baseline because they will not get through it. And so that's a big piece to why having, Melanie Harned developed this adaptation, working with Dr. Foa and Linehan, and a big piece of that is that you're weaving in these skills and you're weaving in reducing the baseline of this dysregulation before you try to open up Pandora's box of trauma work. Okay. So DBT has several modes within the treatment. And this is one of the aspects of the treatment that I think is so important because it has these components that really all kind of intertwine with each other and try to set the client up as much as possible for really being able to dig in and stay motivated and committed to the work. And there's also the component where the clinicians support one another formally. Because there's a lot of teams that aren't DBT teams and clinics and what have you, where people definitely support one another. And in this treatment, there's a kind of a formality to that and a structure to that that is actually preemptively built in, because there's so much that can go on with this population that can be very impactful. And so we want to be able to support one another. So the pre-treatment process is where the client meets with the therapist, or sometimes this is initially done over the phone, and they talk about what DBT is. So we give an overview. We do psychoeducation right away so that the person knows what they're getting into. And then also in pre-treatment, we talk about what a target behavior is, which is the behavior that the person is doing to try and deal with that emotion dysregulation and that heightened sensitivity, yet it's destructive to their lives or to their physical being. So we call, and we want to either completely get rid of it or reduce it or what have you. And so that's a target behavior. So we determine those target behaviors with the client ahead of time in pre-treatment. And then we talk about commitment. Are you willing to take suicide off the table as a problem-solving option? Are you willing to take self-harm off the table as a problem-solving option? We know that you may say that today, and then you're probably going to slip back into wanting that to be a problem-solving option. Are you committed to working on bringing that back around, your commitment back around, and taking it off the table again? So we know we're asking for this 100% commitment and abstinence from the behavior, and then also knowing that the person is going to have moments of struggles. How do we prepare for that ahead of time, and getting the commitment that they will continue to be committed to bringing it back, to removing that behavior, and also that we can remind them, hey, we talked about this in pre-treatment, these were your life worth living goals, how is this behavior pulling you away from that, and such and such. And we also have individual therapy once a week, and in that session, I'll talk a little bit more about the details of that. We have individual therapy and then skills training group once a week as well. And we separate those out because there's so much that can go on for someone that it is very difficult to, in a 50-minute session or even a 90-minute session, get in the psychoeducation of a skill, as well as doing what's needed in the meat of the therapy session. So we separate those out so the therapist and the client don't feel so squeezed and so rushed, and they can really have each component allows each to have its place and address things separately. And then phone coaching is when someone calls their therapist between sessions. And the idea with this is that it's a structured, brief interaction, and the client is prepped on this in individual session ahead of time of what to expect. Again, always wanting to lay out psychoeducation for what am I getting into, what's going to be expected of the therapist, what's going to be expected of the client. And they call and they say, I have this situation going on, and the person may have urges to self-harm, the person may have urges to verbally lash out at a family member, and so they're calling and saying, here's my urges. They're stating what their subjective units of distress or SUDs are. We usually rate those from 0 to 10, with 0 being no distress and 10 being the most distressed ever. And then we go through, okay, what are some skill options that we can do? Are you committed to doing opposite action? How can we make that work in your environment and within yourself? Great. And then go forth and do that. And maybe we have a follow-up call later. I'm making that sound like it's really neat and easy and clean, and it's not usually at the beginning, and then you kind of shape the client into it. But that's the basic premise. It's not another session. It's not just, it's really meant to be like 15, 20 minutes max. And if you find yourself going over, that's something that we talk about in the individual session. And I'll talk about that in a minute. And then the consultation meeting, like I said, is a meeting for us to support one another. It's for case conceptualization, and it's for also making sure that we're adhering to DBT and that we're using the skills as well, okay, as clinicians. So in the individual session, you come up with a target hierarchy. I'm sorry, you don't come up with that. You map out the client's target behaviors on the target hierarchy and kind of review this. We develop a diary card, and we engage in behavioral chain analyses and solution chain analyses. The target hierarchy is there to help us organize the session, because a lot of times our clients can have so many crises going on at once, and they usually want to talk about the thing that's not what I'll describe as level 1 here. They want to talk about something with the intimate partner or their friends, or how frustrated they are with a job situation or what have you. And so we don't want to get distracted by that, because if someone's not alive, then they can't work on those things. So we have to start with the life interfering behaviors, the level 1s as we call them. So again, we explain this at the beginning, that the diary card is a self-monitoring tracking kind of chart that people fill out every day, and it has a list of their target behaviors, urges for them, and whether or not they engage in the behavior, and then also 0 to 5 experience of various primary emotions. If someone comes in and they are struggling with suicidal ideation and self-harm or something to that effect that's harmful to their life and physical being, we have to start with those. If they're not safe, then those other things don't matter. So we start with that. Level 2, therapy and interfering behaviors can be on the part of the client and on the part of the team or the provider. So usually therapy interfering behaviors are things like not doing their homework or their diary card, being unwilling to do a behavioral chain, being disruptive in the skills group, calling it effectively for coaching. And then on the therapist end, they can do things like not following through with certain interventions because the client is uncomfortable or reports anxiety, or that they are late to sessions often, or things like that. So in that collaborative sense, we're trying to show our humanity as well as providers, and being able to own when we are doing things that aren't effective, and be honest with the client about that, and talk about how we're going to do differently, just like we're asking the client to do the same on their therapy interfering behaviors. And then quality of life, those are things like relationship stuff, frustrations with work, anxiety, anger, depression. And this is also where usually eating disorders and substance abuse fall. But if they become intense enough, we'd actually bump them up to level 1. Okay. So how this also relates to the adaptation of DBT with PE is that if someone is perpetually engaging in behavior that is bringing them closer to life interfering behaviors, then they cannot do trauma work because the dysregulation and the inability to tolerate affect and the inability to move away from engaging in their urges is so strong, again, that person would not fare well in starting trauma treatment at that point. They would probably end up even escalating more if their baseline was at that place. So again, this is another reason why having that hierarchy and having that as a guideline is helpful for preparing the person and also letting them know what's going to be expected of them, which I'll talk about later, in order to start trauma work. Because a lot of our clients will say, oh, I just want to jump to trauma work because that's going to make everything okay. That's the problem. And so there's a lot of psychoeducation about you have to be in a certain space in terms of your ability to take care of yourself and navigate difficult emotional experiences before you jump into that process. And with therapy interfering behavior, if you have someone who doesn't do their homework regularly and things of that nature, that's not going to work as well, at least with most trauma therapies, but especially with prolonged exposure, because there are various homework assignments for in vivo exposure outside of group that they have them outside of session that they need to be doing in order to get the full therapeutic dose of the treatment. So all of those things are addressed ahead of time within the regular DBT work before the person goes into prolonged exposure, and then we'll talk more about along with as well. So we have chain analysis, and that is the crucial intervention to the individual sessions. And the chain analysis is something that we do when the person has identified a behavior that they want to change or to stop doing. And we see that on their diary card, they have reported that they actually engaged in that behavior. And again, this can be anything from the level 1 behaviors of, maybe even trying to go towards planning for suicidal ideation, or engaging in self-harm or what have you, all the way to, again, like verbally lashing out and things of that nature, or emotionally eating or restricting, and ineffectively taking medication. All of those things we chain. And so this, I'm kind of a dork. I love this. The first time I was taught, it was taught to me, I was like, this is amazing, because it really just encompasses everything, but in this very like compact and clear way. And most clients will find that this is inadvertently an exposure to intense emotions, which again, linking to the prolonged exposure work, can be beneficial in prepping for the imaginal exposure part of prolonged exposure therapy, and saying to them, we want to start habituating to the experience of doing a chain and the fear and the anxiety of, well, if I go back and look at something that was upsetting, that I'm not going to be able to handle it. And so we try to habituate to this in terms of being able to say, this is prep work for being able to address the trauma, because we've got to be able to tolerate the distress in doing this, because this is going to be one level of distress, but the trauma is going to be probably even more. So this is another opportunity for exposure to experiencing emotions and tolerating affect. So the chain analysis has these components. We have a behavior that we identify that we're chaining. So again, let's say it's verbally lashing out. And then we identify the vulnerabilities that may have been going on for the person internally and externally. So within themselves and in the environment, like they could have not gotten very much sleep the night before, and maybe driving to work, there was a ton of traffic that was frustrating. That used to happen in LA more. And other vulnerabilities might be relationships with certain people, and knowing that going into that there's already going to be some kind of pull to be ineffective. And then if the person can identify the prompting event, the thing that was happening in the situation that kind of set everything in motion to get to the behavior, that's great. Sometimes we have to kind of start the chain and it'll kind of come up as we're doing it. Oh, that was the thing. That was the thing that kind of set me off. And those are the things that are helpful in thinking about for the future and solution analysis, to be signs to help the person know whether this scenario that I'm going to be going into, there are high vulnerabilities, so I need to be very skillful and aware of what skills I'm going to use ahead of time, or it might be a specific person, it might be lack of sleep, things of that nature. And then we have the links in the chain and the consequences. So I'm going to jump to the next slide. This is very fun. So we have our vulnerabilities here. We have our prompting event. These are all these links on the chain and that lead to the problem behavior. And then the links, these individual links consist of, nope. Okay. They consist of chunking. So we have an event and we have an emotion or emotions that come up with that. We have thoughts that are linked to that. We have body sensations and we have action urges that are all chunked, and we just keep going through in chronological order, chunking along the way. Sometimes clients have a hard time either determining what the emotion might have been at the time or determining their body sensations. A lot of our clients struggle with actually being in their body. And so this is something that as we're starting chaining with them, we'll learn about to help with mindfulness skills and grounding techniques and what have you to develop more awareness around that. So we go through those chunks till we get to the behavior. And then we identify what were the negative and positive consequences of that behavior. We want to acknowledge what the positive consequences are so that we can dialectically acknowledge through validation and change, hey, that makes sense why you're doing this. That makes sense why the pull is so strong to engage in this behavior. And look at all these other ways that it's so destructive. So we want to validate that it's hard because there's such a pull. There are positive consequences while also trying to get that commitment stronger and stronger as they move into, okay, this is so destructive that I need to find a different way of taking care of myself than using these behaviors. And again, this goes with moving into the trauma work, that if people are using target behaviors at a regular rate, usually what happens is that they're behaviors that squash the emotion experience very quickly. It's a very quick, immediate experience of relief, and then it comes back afterwards. There's all these secondary effects from doing the behavior. So we don't want that avoidance of affect continuing, that cycle continuing at a high level, because then when they're doing the trauma work, again, they're not going to get the therapeutic dosage because they're going to be trying to avoid the experience of these intense and difficult emotions. Okay. So where we can make changes is with the solution analysis. So we go back to that chain and we say, oh, you can't see, going to take my finger and kind of point at the links in the chain. And basically the idea is that we try to weave in those sections, where in the chunk, what was maybe the thought that we can do a thought record on for the future to move out of judgment and move into non-judgmental stance. What were the body sensations? So we can use mindfulness skills to build greater awareness that when someone's getting upset, maybe they feel flushed, or they start to have tingling sensation or what have you, or their thinking gets really clouded. We also might say, this is a place to call for coaching, so we want to intervene there. So we go through those links and try and figure out where the person could have intervened, so that in the future they're not even getting to that behavior or even close to it, and that will accumulate over time. And again, for solution analysis and thinking about preparing for trauma work, it's that people talk about, these are the things that skills that I'm going to be using for suicidal ideation or self-harm or avoidance behaviors ahead of time treatment, because most likely these things, if they've reached a lower baseline, will start to creep up because of the work. And so ahead of time, they have an idea, cope ahead for which skills they're going to use as they face something very difficult that will bring up urges for those behaviors. Alrighty. Oh, that didn't happen before. So exciting. Well, instead of my finger, that's what that would have been. Oh, wow. Okay. So last but not least, for the model, the treatment model for DBT, we have those modules that I was talking about before that are addressed in group. Sometimes we do some psychoeducation in individual, but they're addressed in group. And here we have the dialectic of acceptance and change. And listed under acceptance are the modules mindfulness and distress tolerance. So these are skills that are experiential, that we're not necessarily trying to change anything. We're just trying to be present and aware, noticing what's happening. And distress tolerance, it may be that we're just trying to get through the moment without making it worse. That's always the mantra. This is already tough enough. Let's not make it worse. And so we have the distress tolerance options there. And those are a lot of things that are around self-soothe, temperature, distracting with activities. And then we also have radical acceptance and turning the mind in there. And then the change-based strategies are, or modules are the emotion regulation module and the interpersonal effectiveness module. And this is where you'll have things in emotion regulation like opposite action, trying to do things in your environment to reduce vulnerabilities, whether it's with your own physiology around sleep and eating and taking meds effectively and exercising effectively, to things like understanding better a model of what happens neurochemically and in terms of our autonomic functioning, as well as our things that you can see on the outside that represent emotions in terms of facial expressions and behaviors and thoughts and things that we say and what have you. So understanding all that goes into having an emotion. And then interpersonal effectiveness is really what it sounds like, is trying to have skill options where people are more effective in how they convey what they need in a relationship, how they convey limits, observing limits of people if people are taking on too much from them, and being able to have self-respect as well. So those are the 4 modules from the skills group, and the 2 dialectics that they represent or encompass. And this slide is just kind of breaking it down further, that on the acceptance side of things, skills that they're teaching: self-acceptance, problem acceptance, affect tolerance, and effective help seeking. And then on the change side, it's enhancing skills. It's developing stronger problem-solving options so that suicidality is not a problem-solving option, for example. Affect regulation, and building a sense of self-efficacy, building a sense of I can tolerate this, manage this, handle this, that I don't have to fantasize about not living as a way to handle it. So that's where we're at in terms of taking a break for questions. And I'm just going to hop up and close my window real quick because there's a helicopter and I'm not sure if you guys can hear it. So Michelle, if you want to start.
Thank you.
Hold on.
Thank you. Yeah, we'll give you 1 minute.
Okay. All right.
There you are, she's back. Okay, we had, that was very thorough, thank you. We had one question pertaining to interfering behaviors. The question is, if interfering behaviors are addressed before quality of life concerns, I imagine this could lead to clients minimizing or not reporting SI or NSI. How is it possible, how is the possibility of underreporting addressed?
Absolutely. I mean, oh, it's a little bit of a echo, Michelle. That's weird. Okay. Absolutely. This can definitely come up. What I've found is that it's less about underreporting on the, which, you know, on the diary card, that's what they report, and more about reporting it and then just like pushing actually in the moment of session. No, I don't want to talk about that. I want to talk about the other thing. So underreporting, when that's happening, that's in general is something that we address by talking about commitment, talking about the relationship, using a lot of commitment strategies, dialectical strategies, trying to get at, you know, is it driven by that the person wants to be able to talk about these other things? Or is it driven by that fear of actually addressing these things and having that exposure to emotions and trying to validate whatever those barriers are? So we may spend multiple sessions on that to get the person back to a place where there is honesty on the diary card. Also, things will tend to come up. Our clients who struggle with this aren't very good at hiding things for too long. We have the dialectical dilemmas where you look at, you know, parent competence and active passivity. And so people can come across like everything's fine and going well. And then, you know, you scratch below the surface and things do crumble pretty quickly. So of course, the hope is that it's not that you get a call that someone's, you know, in the hospital kind of crumble, although that can happen. But little things will come up along the way that can kind of alert you to, really, you're telling me that this is a situation where you usually self-harm and that hasn't happened. That's great. Let's see why. Or that it'll come up, well, actually, you know, the other day such and such happened. The same with substance use as well. So usually things will alert you that something isn't quite what's being displayed. And to move out of that, it's a lot of validation and a lot of commitment strategies. So I hope that answered the question.
Great, thank you. Again, we invite any questions you might have. Just pop them in the Q&A section. I think that was the only question for now. So if you'd like to proceed with the presentation.
Great, that was a great question. It's important because the honesty piece on the original diary card, actually I forgot to say this, lying is a target behavior and it's just on there indefinitely for everyone. So that's also a very front and center conversation about, you know, you're only going to get so much out of the treatment if you're honest about what's going on for you. All right, so let's segue into, we've talked about the criteria for, or the 5 areas of dysregulation and what makes up the experience of borderline personality disorder. We've talked about the treatment as it is in DBT for that. So let's talk about trauma. We know that so many of our clients have had some sort of experience of trauma, and how difficult that is, how impactful the residual experience and impact of that on people's lives. And again, the example of active passivity and apparent competence, that there are a lot of people who are out in the world who have had some experience of trauma or some sort of traumatic experience, and they can go along doing okay and leading their life. It does, for our clients who are in the more kind of clinical population, or who actually make it to the clinical population, there is a hope that there's some recognition, if it is having an impact on their life, that they are coming to get help instead of just trying to white knuckle through life, or falling into active passivity, where then they kind of are help seeking in an ineffective way, or giving up self-efficacy, and things are falling apart around them, and the other people in their lives are close to them are, trying to keep them afloat. So it's really important that people seek the help. And like I was saying, again, a lot of clients will want to come in and right away jump into the trauma work without the skills. And whether you say the skills from DBT or CBT or psychodynamic treatment or what have you, they still need to have some sort of shift in the baseline of their emotion dysregulation to then do the work, or else it just they can't complete it, and then we've opened up this kind of wound, and it's just not being resolved. Okay, so I am actually going to go through these criteria from the DSM-5 because I just want to kind of call attention to the overlap in the description in some areas between PTSD and borderline personality disorder. So first and foremost, to get a PTSD diagnosis, we have to have an exposure to an actual or threatened death, serious injury, or sexual violence. The intrusive symptoms, for example, can be distressing memories, flashbacks, re-experiencing nightmares, dissociation, psychological and physiological reactions. And then avoidance of various things that are internal and external reminders of the trauma or reminder adjacent. And then cognition and mood changes happen, that a lot of clients who've had trauma, they have memory impairment, not like dementia, but more kind of spotty memories of experiences, not just the trauma, but around the time frame of the trauma. That there's a lot in terms of cognition of negative beliefs, blame, negative emotional states, anhedonia, and detachment. And then, of course, the criteria of arousal and reactivity, that they can be very hypervigilant to their environment. That can also create a lot of irritability. If you're not sleeping well, having a lot of nightmares, that also can contribute to anger and irritability. And then struggles with concentration and impulsive and reckless behavior. So, I mean, very much so, a lot of our clients who struggle with BPD and maybe don't even have a trauma background, but also the ones where there is that overlap, there's a lot of experience of dissociation, a lot of escaping outside of one's body in that way, a lot around avoidance and avoiding anything that brings up that heightened sensitivity to emotions or any kind of anxiety in general. They don't tolerate well. And then one of the things that was the most striking to me when I first worked with clients from the DBT PE adapted model was the intensity of the self-blame Part of the initial assessment in the beginning sessions of PE is that you talk about, from kind of a pie chart perspective, what the client's experience of blame, self-blame, is for the abuse, and what the perpetrator's blame is, the percentage of the pie. And I would say that the majority of the clients that I've worked with, their self-blame was 85 to 90% at the beginning of the treatment. Excuse me. So there's just a really intense sense of self-blame and negative sense of self and judgment that that people with PTSD can carry around. There's also both that, and someone can have a really intense amount of anger as well, understandably so. But a lot of times, even with that anger, there's the self-blame. Sorry, hold on just a sec. All right, so those are the kind of comparisons of the two. We have various treatment modalities for how to engage in working on trauma. So PE is not the only one. I think as Dr. Harned was going through and doing work with clients and finding that so many of them were actually being excluded from prolonged exposure options because of the pervasive and active suicidality, and because there are aspects of PE that really do fit nicely with the theoretical orientation of DBT and the philosophy of it, that she was able to kind of develop this together and link them together. But this isn't the only way. CPT is sometimes considered a more palatable, softer version of the imaginal, instead of doing the imaginal exposure, which I'll describe in a little bit. CPT has it, it's written. So sometimes people will say, PE is kind of harsh for a lot of clients and the clinicians. It's tough to go through, and it's tough to be, as the clinician, the one who's kind of pushing the process along, and knowing that the person is having a really intense experience. So CPT is another option. EMDR absolutely is another option and has been beneficial. The Seeking Safety Protocol, also somatic experiencing, neurobiologically based treatment, and of course ACT. What we've found, at least because I work in a residential setting, so our clients are not only struggling in terms of the basic emotion dysregulation, but also even kind of the engagement in life, or being able to get to treatment and things of that nature, maybe a lot of hospitalizations over and over again, and just kind of stuck in that rut. At this level of care, we have found that somatic experiencing is possibly a little bit too intense without the skill set, even more so. And yet, once someone who has struggles with BPD does get that baseline way down, I think somatic experiencing can be huge, because a lot of trauma is pre-verbal, or that we can't, that there are people who, going at it from a verbal, semantic, narrative approach is not going to be beneficial for them. And that's the importance of having various options, because clients aren't one size fits all. All right. So you can see, 50% of BPD clients have comorbid PTSD. It's really, it's problematic if it's not treated. And again, like I've said, if we jump into it first, that's also problematic too. And the numbers in terms of, the self-harm and suicide attempts, for clients who, if they're not getting any treatment and any help and what have you, it's really high. And that along with the trauma symptoms, that doubles the risk for them. So this is something that, you know, where it needs to be addressed in some way, shape, or form. So we're back to the biosocial theory because the idea that so many of our clients have had this experience from the social piece, from the environment, that you have this interaction, this transaction between the biology that the person brings to the table and how the environment responds to them from an early age and how they respond to the environment. So if you have a client, we call this the poorness of fit, who's got other siblings and their parents are like, oh, they were gems and it was fine, but this one, you know, was colicky or was always having a hard time. We couldn't get them to stop crying and yada, yada. So they're already growing up with this narrative that they're like the problem. And so as much as a lot of parents try so hard to figure out what to do for a child who they can already see is having these struggles, so we call it like inadvertent invalidation, where things like that may be said or they may not be, and yet there's still this experience that they may see their siblings doing really well and they're not, and that ends up being an invalidation of themselves. So you have those kind of inadvertent invalidations, and then you have actual abuse, emotional, physical, sexual abuse, neglect, you know, whatever the spectrum of options for abuse can be there. And so this is just another way where, again, you have this kind of crossover with the BPD and the PTSD, and that the biological piece, again, that when someone experiences trauma, again, there's heightened cortisol levels, impact on the brain, again, the limbic system, family here, amygdala, hippocampus, what have you, kind of throws this tidal wave over the frontal lobe, which is where our reasoning and our logic and analytical thinking is. So, you know, it's very tough to have these kind of interactions in our experiences, because they do literally impact our psychological functioning. Okay. So let's talk about prolonged exposure therapy and its model on its own, and then we'll talk about the adaptation with DBT. So this treatment was developed by Edna Foa, and it's, you know, been something that's been around for quite a while, and definitely was used with various populations, war victims, rape victims, and sexual assault victims and things of that nature. And so it is cognitive behaviorally based and exposure based treatment. So right off the bat there, DBT is based on mindfulness practices. It's based on dialectics, the idea of having two opposing things going on at the same time. And it also does have some remnants or some sprinklings of cognitive behavior therapy. So there's a way in which these two, DBT and PE, already can have an exposure as well, like I was talking about with the chains, for example. So there's a way in which these are already kind of set up to complement each other in terms of their natural kind of being. And so the PE modality has 13 sessions, and basically we'll go over that in a little bit. But the first session, the first couple of sessions is really the idea of doing psychoeducation about, what you're going to be doing in the treatment, strengthening the commitment for the treatment. So again, kind of similar to DBT, developing a post-exposure skills plan so that the person isn't just kind of going in white knuckling it. And then in the second session, they start to go over psychoeducation for the rationale of exposure, like as a concept, and the exposure and trauma work. You go over what a subjective units of distress SUD scale is, so the person understands that, because that's going to be the main way that the person is rating their experience of their dysregulation, and along the way in other aspects of the treatment in session and outside. So they need to be aware and familiar of that language, and really being able to determine what's their kind of most intense point on that scale. And then also learning about what the in vivo hierarchy is and developing that list, that hierarchy list, for the in vivo component outside of session, which I'll describe in a little bit later. And then after that, the rest of the sessions until the last couple of sessions at the end are what I'm going to describe in a minute, and what the components of that are. And then you have the relapse prevention sessions at the end. So we've moved into working on what have we learned, summarizing what have we learned, what have we taken away from the work, the shifts, and then how do we stay connected with that? Because a lot of clients will be able to be connected with it right away, and then over time, just like with anything else, as we get further away from the experience, it lessens in terms of the kind of charge and power that it has. And so we want to have people walk away with notes and cheat sheets about that, so that they can keep going back to and connecting with it when that charge starts to die down, and to help them and prevent like a relapse as much as possible. Okay. So the rationale for the treatment was to get people out of this cycle. So when we experience a traumatic event, there's a behavioral pull for avoidance. Whether that means that the person just completely withdraws in general from all of life, and becomes maybe agoraphobic, or just pulls away from relationships, pulls away from work, and just completely shuts down. Or it might be in more subtle ways, or ways where it's just relationships, but they're still able to do work, or they're still able to do some basic things. But either way, there are various ways that behaviorally that they're not taking care of themselves. And it might be their ADLs, it might be feeding themselves, shopping, grocery shopping on a regular basis, going to the doctor if they have a medical issue. That's something when I was working at the Palo Alto VA in the behavioral medicine clinic that was problematic. We did a lot of work with Vietnam era vets who had medical issues, and they were avoidant of coming in and things of that nature. And so that avoidance, that behavioral piece. Then we have the thought process piece, the problematic beliefs that stem from the trauma, these kind of generalizations about the lack of safety of the world after that experience, the inability to trust, no one can be trusted, things, beliefs and thoughts that then perpetuate avoidance. They pull for avoidance. And then if someone continues to avoid and not get out there in life and have experiences and see that not all experiences are what they fear, then that avoidance of getting out there strengthens the problematic beliefs. And so we just have this mess of this cycle that's just feeding on each other. So, you know, it's very difficult to get someone to put themselves in a position that they're terrified about, and to break this cycle. And again, that's part of working on the idea of the psychoeducation and really explaining ahead of time and taking time, you know, and that may not be only one session, frankly, depending on what's going on for the person, to get that buy-in and that understanding. We also, yeah, okay. So going on to the next one. Okay, so in the main sessions in the middle phase of the treatment, after the first 2 sessions and before we go into the relapse prevention, we have essentially 3 components, 3.5 basically, of the procedures for prolonged exposure therapy. 2 of them occur in session and 1.5, I guess you would say, occur outside of session. So the imaginal exposure is the really kind of intense part of the work, because basically you're setting up the session for the chunks of time that you spend telling the narrative of the trauma. Actually, I'm just gonna, oh, okay, yeah. So I'll go into that in more depth in a minute. So we have the imaginal exposure, which is that telling the narrative. It functions to stop avoidance of traumatic memories and thoughts. And then in session, after we do that part, we have the emotional processing, which is really similar to doing cognitive modification, in that you're working with the person on shifting these problematic kind of staunch and self-judgment, self-blame beliefs and getting a new perspective. And then the half, I would say, outside of session is that you listen to the session outside of session on the days that the person doesn't have the session, to keep the exposure going and to hopefully aid in habituation sooner. And again, I'll get to that more in a minute. In vivo exposure is outside of session, and that's what the in vivo hierarchy list comes in, which I'll go into more depth. But this is the part outside of session as well, where the client will go and do things to confront the urge to avoid. And we make a list of those things. And this is the part that's the another behavioral piece in terms of that cycle, the avoidance piece, getting at that behavioral piece to try and impact those problematic beliefs. So before we would do the imaginal exposure, and even before in the kind of initial, before the session 1, there's a whole kind of assessment handout with questions that you're not only asking the client about the trauma. You're not going to go into as much depth. It's not as much about the narrative of the trauma as much as trying to find out what trauma happened, and if there's more than one, taking the top 3 if there's more than that, and then trying to determine, first and foremost, does the trauma, would it be a narrative that has a beginning, middle, and end to the narrative? If there's not enough to the narrative, if the person doesn't remember enough, if they can't describe, and again, that's why I say this, it's good that there are other trauma options, because highly verbal non-verbal or highly verbal clients, or if they don't have enough information for the narrative, they've got to use a different modality. So we're assessing for having the beginning, middle, and end narrative to have enough there to do the imaginal exposure. And there's also questions about the trauma and how much it's impacted the person's core beliefs and sense of self and avoidance behaviors in their life, because we really want to choose to start with the one that has that kind of impact on their life, because then we're being able to really get at those things that are keeping them from being fully functioning in that process. Okay. So once that's determined, then we engage in the imaginal exposure. And so basically, and this is, I'll talk about the adaptation with DBT of how the structure of this session looks a little bit different. But basically, we want the person to tell the narrative out loud over and over again for as long as they can. And again, I'll talk more about that in the adaptation part. So we want to spend the majority of this big chunk of the session, and that is the focus. And the person's narrative could be 5 minutes, or it could be 20. And so at least we're trying to get through, a couple iterations of it and to have that exposure experience. And as we go along in doing that, the clinician will ask the client what their SUDS level is along the way. And so we're tracking that the entire time. One, to get a sense of when the client will start habituating from the higher SUDS levels to lower, and that'll demonstrate that they're making movement in terms of reducing the power that the experience has, and the fear of telling the narrative and the fear of facing it, reducing that power, reducing that anxiety, and that they're starting to really build this into something that's about themselves and their life narrative, and not getting so something that's outside them, that's intangible and intolerable. And then what we do is, as those numbers start to decrease, but there may be places in the narrative that you can see that the person's not habituating to, or that they've reported in the emotional processing that is their hotspot. So once we've got a certain level of habituation of the entire narrative, then we go back and start again in choosing smaller hotspots to focus in on and do the same process. This goes on over time, not all in the same session. Okay. And the person is assigned homework for the audio. So the clinician is, during the session, ranking or tracking that SUDS level and asking the client. Then we ask them to do it themselves with a worksheet that, while they're listening to the session at home, which looks at urges and, well, this is in the DBT, but anywho, the ranking for themselves what their SUDS levels are and what have you. So the in vivo exposure, like I said, is the part that's outside of session. And this is where the client and the therapist will talk about what are the things that you avoid in life. And then they'll make a list from ranking it from 0 to 100, with 0 being no avoidance and 100 being like the most intense anxiety about something and avoiding it. And they'll list several things, and they'll give it a SUDS number. And then they'll say, okay, we're going to start, we don't want to start too low, because then it's not going to feel like any kind of challenge. So we'll maybe start in the 30s or 40s of some kind of activity that the person needs to go and do on their own outside of session. And then again, they'll also rank their SUDs throughout and what the experience was and if they're able to do it. And then you keep going up along the intensity of the list. So we don't want to jump to an 8, but sometimes, or an 80, but sometimes things will happen in life where people inadvertently get kind of into a situation that they didn't expect. That's something that they avoid and is higher on their list. But usually we want to do it systematically and planfully. For example, a client who I was working from an in vivo hierarchy list, not doing full-on PE, around driving in Los Angeles, and she accidentally got into a situation that was an 80 for her. And so she actually was very proud of herself because she handled it, and we got a good laugh about how that was not what was supposed to happen, and there's some things that we just don't have complete control over. And she didn't revert back to refusing to drive at all, which is great. However, something like that can happen if we jump too high and too fast. So systematically doing that. Also, we don't want to choose things that are legit unsafe. So if we have a client who's been assaulted in a dark alley, we're not going to ask them to put that on their list. That is really something that, just in general, we want to be careful about. Probably not going into dark alleys if it's possible. So we wouldn't want to habituate someone to a healthy concern about going into something that's not that tends to not be safe. We want to get them to go towards the things that are safe and life affirming that they're actually missing out on because their avoidance is overgeneralized. Okay. So here's an example of an in vivo hierarchy. See how these can kind of, how they kind of increase in intensity as you go up the list. Okay. And we have a few more slides and then we'll be able to take some questions. So, and then the emotional processing piece is, like you said before, the really similar to cognitive modification and restructuring. And it's very active at the beginning on the therapist's part to challenge the beliefs of the client, because that self-blame piece is so ingrained that it's really hard a lot of times for the clients to see any other way or perspective. And so we'll offer up some ideas from a Socratic questioning, which I printed those out, but I don't think we're going to have time, piece of trying to get that rigid thinking to open up, to get some flexibility in it, to move out of the all or nothing and into some sort of gray, at least. We're not looking for a Pollyanna-ish experience where the person is all of a sudden, saying, I'm so wonderful and amazing and I have no self-blame or anger towards myself, but moving out of it in a way, because those thoughts can be so self-destructive, especially in terms of self-harm behavior and questions around deservedness and things of that nature. And it's also a time where the client can sit through the narrative and then have the processing part and see that the therapist is not treating them differently, not blaming them as well, just there to support them and go alongside them in the process. Because unfortunately, a lot of our clients who have had trauma do have people who in their lives who engage in a lot of blame. So here we are with what I was talking about before, a part why Dr. Harned kind of started moving into this idea of combining DBT and PE. It's very difficult for people who have chronic suicidal ideation and active suicidal ideation to be doing the trauma work or to be accepted into the prolonged exposure therapy option for treatment, for example, and a lot of other trauma work as well. If someone is in and out of the hospital for suicide attempts, if they're constantly engaging in self-harm, if they're constantly engaging with substance abuse ineffectively as well, or eating disorder behaviors, any of these behaviors that are reducing the experience of emotions and kind of shoving them down and not learning how to have affect tolerance, then they're not going to be appropriate to start the therapy, the trauma work. So, so what is beneficial about this adaptation is that clients in DBT learn how to strengthen their skills base. They learn how to reduce the baseline around that spike in emotional experience and the slow return to baseline. And they do an intensive amount of work on removing suicide as a problem-solving option. And so there is all of this work in that foundation that can take however long. And really, as the person is moving out of the more intense stage 1 level of treatment, that you can start doing the psychoeducation, doing the planning and the coping ahead for what PE is going to look like and how they're going to navigate that they most likely are going to have an increase in urges and vulnerabilities at the beginning of the treatment, probably even midway through, as they're facing something that's so incredibly difficult. So they've got those skills, they've got those cope aheads that they've been using for this intense work around safety and suicidality as well. And, you know, then being able to talk about how are we going to also like apply this to this other work. And like I said before, there's some experiences in DBT that are analogous to some sort of emotion exposure. And so also relating that to the client as well. Hey, you've done this a bit already. So we've already, you know, kind of developed the skills around it. It's not going to be starting from scratch. That's so exciting. Like we don't have to start from scratch in that kind of experience. So we're already working on that. An important piece of the adaptation, let me just see, is that we keep one DBT session a week. And this is beneficial in terms of tracking skill use and having a session that's just solely about like kind of the norm, how are we doing in life in general, and while also not losing the experience of consistency with the trauma work. And it also helps to be able to track if the self-harm and SI urges or any other ineffective target behaviors are going on that could impact the experience of the therapeutic dose of the treatment. So we can track that along the way. You have your own session to deal with those things because those would be considered therapy interfering. And then also determining if this is going on too much or if someone's SI is getting too intense, then we will take a treatment break and come back. And that's not ideal, but that is built in to do that. So I think that's a real strength of the model. And you're also continuing to connect with, this is not new, these are things that I've been using before, and how do I'm going to stay connected with them because, and I'm still calling for phone coaching, still seeing a therapist regularly. So we're not totally removed from that support session and the support of the DBT model in general. So the adaptation essentially is that you have one PE session, one DBT session per week. In the PE session, which I was saying with the regular PE you don't do, but in the DBT adaptation, you do look at the diary card in the beginning of session. And then you kind of note maybe what's going on and what have you. And again, if there's some kind of major shift in safety, you have to address that. Not, can say for the next session, we're going to address these things and what have you. PE typically begins 4 to 5 months into DBT. And this really, this depends on what's happening for the person and the consistency that they can maintain in terms of the level 1 reduction of level 1 behaviors. It doesn't mean that they don't have to keep it reduced the entire 4 to 5 months. We're looking for at least 2 months of no suicide attempts and, planning or anything like that, and no self-harm. And then after the PE is over, then they resume back into traditional DBT, which is also great because then they've developed those relapse prevention COPA heads from wrapping up the PE with that particular therapist or someone on that team. So again, it's someone who can help them keep coming back to that information. And I think we said all this, that, yeah, the DBT strategies prepare and motivate the clients to get ready for PE. And that this is an adaptation that's designed for clients with complex, severe trauma histories and suicidal behaviors. So it's definitely for when, things are very, very intense. And just trying to think anything else I was going to say about that. Readiness for, just in terms of the setup. The session breakdown is the same in terms of, what you're covering in the PE sessions. And then, like I said, you have the one DBT session a week. Readiness for DBT and PE, like I said, no recent in the past 2 months life-threatening behavior or self-harm. There's a demonstration that they can manage life-threatening behaviors, and that the client is committed to working on it and willing to and able to tolerate intense emotions without escape behaviors. And just a couple more things and then we can do questions. Sometimes barriers to treatment, someone's all in, they're all prepared, and then we have a struggle around over and under engagement, or the self-harm behaviors come back up, or someone struggling with an ability to follow through listening to recordings between sessions, or an intense anger response, which is one that kind of takes kind of longer to sort out. The under engagement is when people kind of move straight into dissociation during session or when they're listening to the recording. And this is problematic because they're missing out on the therapeutic dose of the emotional experience of the distress and trying to bring it down. And so I'll show you on the next slide some things that we work on for that. And the over engagement, if they're hysterically crying and having panic attacks during session, then we're not getting anything done. So we talk about that in the DBT session. And so some of the things that we'll use are the main distress tolerance skills: ice dive, frozen orange, essential oils, holding a smooth stone, silly putty and Play-Doh at the beginning to help just bring either up the engagement or down. But we don't do this for a long time because we don't do this persistently throughout, because then that's helping with the habituation inadvertently without it being, kind of coming from the person in the moment. And then that can kind of impact the experience of the treatment. So yes, that's it. I know you want me to answer questions.
Thanks, Dr. Riddle. Yes,
Okay.
it's so nice to see the questions coming
Like,
in.
I'm almost there.
Right. Great. So we'll just start with the first one. Self-blame is so apparent in the work, but I find it to be such a hard behavior to work with, i.e. dealing with an adult, dealing with childhood sexual abuse and blaming. How do you manage that in session? Or do you navigate that self-blame in session?
We navigate it in the emotional processing, and that's where the idea of trying to give some ideas of, hey, how about if we, kind of try to use some of the Socratic questions to look at it a little bit in a little different way. Or so what I found is using things like the Socratic questions is helpful to start. It's like, chipping away, right? It's not just like a poof, like, oh yes, this is, I see the world so much differently. So really validating the pull for the self-blame, not the actual blame, but validating a lot around it's so hard, to not see this way, because this is also, especially from childhood, you're looking at this from the perspective of as you were a child, and trying to just, kind of slowly and gently chip away at it. And then sometimes I'll come in a little bit strong about, adults' responsibility towards children, and be a little bit more firm about it. It really depends on the client, and it also depends a little bit on sometimes with the anger and what have you. So a lot of Socratic questions, a lot of gentle, just trying to chip away at it and pulling from things that they're saying. The emotional processing, you pull from things that they've said in the narrative and the description, and just checking the facts about, what was happening on the adult's part and their part, and the lack of power, which sometimes isn't necessarily soothing to think about either. But anywho, I could go on and on. So those are just some ideas.
Are there any books you can recommend in working with BPD clients?
Yes, I can actually, if it's easier, I can send like a short list. But just some things off the top. I mean, I have here, so the PE therapy book, Prolonged Exposure Therapy for PTSD, by Foa and Embry and Rothbaum. That's actually, I think you can get that on Amazon. I do like, what is her name? I think it's the one of Loving Someone with Borderline Personality Disorder, Valerie Poor, I think Poor. I think the Bessel van der Kolk's book, I've been trying to get through that, not because it's not good, just because work gets in the way. Of The Body Keeps Score, I think is good. And those are kind of the main ones coming to mind. I know there are more, so sorry. I can send later.
Yeah, thanks. Okay.
The Buddha and the Borderline. Hello. Yes.
Okay. Next question. What about family involvement with treatment? What's the best approach for family system to get involved in the treatment? Should the client want his or her family involved?
Okay, great. Two-part question. When there's trauma that's perpetrated by the family, I mean, I think that, if just kind of from a trauma perspective, I think that can get a little bit tricky, really. And then I guess this kind of goes along with the question about if the person wants the family involved or not. What I think can be really beneficial, at least from a DBT perspective, is to have family members work with a DBT therapist individually if a practice doesn't have a family program, to work with a DBT therapist individually, separate, different therapist from who their loved one is seeing, to learn the skills and to learn, especially for the parents, to learn how to parent a young adult or a child who is struggling with BPD. And then in terms of if there's trauma also inflicted by the, the parents or what have you, I think they also need to do that work separately. But and then at some point, either way, that everyone can try and kind of come together and practicing these things maybe with the individual therapist of the client or what have you. But really trying to get the family members into their own psychoeducation work. And I talk to families about this all the time, but not asking you to do therapy literally for you, asking you to learn more about DBT, about observing limits, about reinforcing behaviors, all those kind of things, so that you have the tools to parent effectively, or as a partner, how to partner effectively and what to do for their partnership and with their kids and things of that nature. So I think that can be really beneficial, because if you just have someone doing the work on their own and they go back to the family system and the family system doesn't have any information, it's really hard for that person to maintain change, and it's really hard for the family to know what to do with the change and for everyone not to just fall back into the same cycle.
Great. Okay, we'll take one more question. Any information on the comparison of effectiveness between the various trauma processing modalities? Are they all proven equally effective?
That's a great question. I don't know the breakdown, as I don't know literally like the numbers off the top of my head, but I do know that definitely, I mean, EMDR there's been more research on that, so that's definitely demonstrated stronger outcomes just because there's actually been research on it. When I first started in grad school, there wasn't any research yet, so people were kind of poo-pooing it, but now there's research, so there's more information. I know that, CPT was used in the VA a lot, so I know that has strong efficacy results. And of course, knowing from PE, I don't know as much in terms of research on SE, but I know that does have strong results. The seeking safety protocol and what have you is a little different because it's a group, and like the neurofeedback and all is supposed to be very helpful. And again, I just don't have the numbers, but I've tried to put the ones on there that I know have had strong efficacy. Okay.
Great, thank you. Thank you so much, everyone, for joining us. That was an excellent presentation, Dr. Riddle. Thank you. I would, so we'll go ahead in our follow-up, include a list of the books that Dr. Riddle recommended.
I see someone got it, so that's, great. Yeah, it's Overcoming Borderline,
Great. So did we see a couple more questions come in? Do we have time? Yep, I think we're getting a couple more questions. What considerations might you make with substance abuse being a target behavior for a client in terms of their readiness for PE?
It would be the same as with the self-harm, that they really would need to abstain from that behavior for a certain amount of time. I don't know if it would be 2 months like the self-harm or longer, but definitely, because if not, then the substance abuse becomes a way for the person to, kind of cheat on the emotional experiencing part and the, the exposure, because it's a way to hinder experiencing the emotions at their full intensity. And if we're not doing that, then the habituation isn't accurate. And also the person is teaching themselves that I can't handle this, that the only way I can handle it is by tamping this stuff down with something else instead of my working through it without those things.
Great. I think we have time for one more question. Someone's asking, I have a client who has had a huge loss, 2 suicides, and sudden death of 3 family members, 2 friends, in total over a year and a half. The client is totally detached and not able to process. Also loss, separation of a partner during this time. Where would you begin with this client?
Not with PE. I would start by working on kind of the baby steps around whatever impact might be happening in their daily functioning because of this, trying to shore up or re-strengthen their support system. Really a lot of validation about how intense this is, that, having multiple losses all at once or in a short time period really shakes us to our core. And just, trying to, whatever kind of negative beliefs or avoidance things that were coming up, just trying to, again, this would be from a DBT perspective, chaining, ineffective avoidance behaviors or things that they're doing that are maybe withdrawing in instead of being able to go towards life. And also a lot of work around life worth living goals and connecting with that. I mean, I think this is something that would be, months on end, I think, because that person's probably hurting a lot, and it sounds like they might be a bit more isolated now after all these losses. So definitely wouldn't jump into trauma work yet. But I think that's also a good example
I'll take off my camera though.
of when you choose which target trauma, that it doesn't have to be the one that maybe has the most horrific story, as opposed to the one that has had the most impact overall.
I see a couple more questions coming in here. Have you heard of the flash technique and brain spotting for rapid reduction of activation?
I have heard of brain spotting. I've heard of it, and I don't know as much about it, but I know that that's something kind of becoming more, I don't know how new it is, so I don't want to say it's up and coming, but I definitely have heard of that and want to learn more about it. And then I forget, Michelle, what was the first technique?
Let's see, have you heard of flash technique?
Flash, I haven't heard of that.
Great, all right. Thanks everyone. Our presentation has come to an end. Thank you again for joining us. We will provide again a list of all the book recommendations in the follow-up email. We hope that you will join us for one of our next events. Please visit our website for any more information about our programs and upcoming events. Thank you all and hope to see you again.
Bye everyone, take care.